Hi, everyone. Thank you for joining us today. We're presenting on the 2021 Medicare Physician Fee Schedule, Advanced Practice Providers, Value-Based Compensation, and other compensation issues affecting your affiliation agreements. Joining me today, I have Jason Baldwin, also with Pinnacle, Alex Kraus with Parkview Medical Center, and Eric Leafgreen with Banner Healthcare. I'm going to give them a few minutes to introduce themselves. Let me introduce myself first. I'm Curtis Bernstein. I'm a partner with Pinnacle Healthcare Consulting, doing valuation strategy work associated with affiliation agreements. Jason, do you want to quickly introduce yourself, then pass on to Alex and Eric?
Sure. Jason Baldwin, also with Pinnacle Healthcare Consulting. I came to them into their strategy division. So I work with hospitals, health systems, and providers kind of doing different types of analysis regarding strategy, sometimes compensation arrangements, reimbursement, and efficiency. Alex?
All right. My name is Alex Kraus. I'm an attorney with Parkview Health System in Northeast Indiana. I've been here about 5 years, leading all legal and provider comp related functions for our employed medical group as well as our independent arrangements. Been here for about 5 years, and prior to that, I was in private practice focusing on healthcare law. Eric?
Hi, my name is Eric Leafgreen. I'm with Banner Health in Phoenix, Arizona. Currently Director of Provider Compensation that oversees the fair market value and compliance analysis of all employed and community provider arrangements. Also work on consulting on the development of new compensation plans that we implement with our medical groups. Back to you, Curtis.
Thank you, Eric. We're also very excited that Alex and Eric have helped found the American Association of Provider Compensation Professionals. It's a new organization. I think a number you might be interested in that gives a lot of education around provider compensation, as well as different tools. I know they just did a recent partnership. So I'll let Eric quickly talk about the American Association of Provider Compensation Professionals. Then we'll jump into our presentation.
All right, yes, the American Association there of Professional Compensation Providers is a new organization. It encompasses several professionals, mainly in-house professionals. Alex was a founding member and organizer of this, so I can let Alex speak to more of the nexus of this organization and the goals for the upcoming year.
Yeah. Thanks, Eric. Yeah, the AAPCP, it was really founded, to encourage collaboration and networking amongst individuals that engage in issues related to provider compensation, to provide thought leadership, education, and really to serve as kind of a public body of knowledge on provider compensation. Our membership is primarily of individuals that work exclusively in this area, such as myself and Eric, as well as those that work externally. So, we're professionally diverse. Our members lead and advise and manage provider compensation for healthcare organizations or their clients across the country. And it's really meant to be that nonprofit community that brings together kind of that legal, that valuation, and that strategic aspect of provider compensation. So we're really excited, to be officially launching this year, and certainly very excited to partner with Pinnacle to talk about these important topics, because certainly these are driving a lot of communication and conversation within the association right now.
With that, Jason, why don't you lead us into the presentation?
Sure. Are we able to pull that up? There we go. So essentially, we just wanted to give you a little bit of background about CMS and kind of what's happened over the last several months in terms of Medicare reimbursement for 2021 and what some of the implications around that might be. So as most people know, around December, some of the new proposals come out, and originally it looked like there was going to be a pretty significant decrease in reimbursement for any kind of Medicare reimbursement for CPT codes. There were also going to be a number of other changes around that, mostly around RVUs. So as you know, there's probably, there's several different moving parts that go into how reimbursement is calculated. One of those things is Work RVUs, another one is practice expense RVUs, and another is malpractice. All of those are basically multiplied by a GPCI, which is a geographic practice cost index, which is a location-specific index that kind of localizes values and makes things specific to your locality. So the work, practice expense, and malpractice all create a total RVU, which is then multiplied against the conversion factor. So all that said, there were changes in kind of all those parts. The conversion factor changed, work RVUs changed, practice expense RVUs changed. So that being the case, a lot of health systems kind of panicked and said, okay, what's this going to do to us? What's it going to do to our reimbursement? And what's going to happen ultimately to our physician compensation if you have a comp package that is tied to work RVUs? So the conversion factor actually in 2020 was 36.09. And that was reduced by more than 10% in December, but the Consolidated Appropriations Act came in and kind of mitigated some of that decrease, and ultimately it ended up as $34.80 something. So essentially a 3.3% decrease, which isn't as bad, but it still didn't make health systems excited or physicians that are relying on that reimbursement. But there were some other changes that, again, offset that and helped with that. One of those is E&M codes. So most E&M codes received a increase in both their work RVUs as well as their total RVUs. So 99201 through 205 are those are new patient visits. 99201 was eliminated in 2021, and some of the other ones received, a decent increase in what their RVUs were. That also resulted in a reimbursement change as well. So, some of those increased. There was, a couple that decreased just due to the conversion factor decrease for the year. But overall, both reimbursement and RVUs changed and increased for almost all E&Ms. Similarly, there were changes in the requirements for some of those in saying that essentially the time that was required for some of those visits increased. So for example, a 99204, what used to be a 45-minute requirement was increased to a 60-minute requirement. So again, a lot of changes, a lot of moving parts that health systems need to be aware of. Another thing that changed was E&M codes for the emergency department. Those also got a payment increase, as well as telemedicine codes got a really significant increase in terms of what the payment would be for those going forward. So all that said, we wanted to kind of take a look at specific codes that really changed, and there were some codes that were procedural-based codes that changed, but really at the end of the day, it's the E&Ms that made the significant impact to reimbursement changes for this year, as well as RVU changes. We kind of did some analysis and tried to look at by specialty what the RVU impact really was. And as you can see on this table, some of them had obviously double-digit increases, several around the 20% range, especially for practices that are very E&M based, like family medicine, internal medicine, endocrinology, and some of those others. And essentially, at median, I'm fighting with my screen a little bit here. My apologies. But at median, a lot of the RVUs changed between essentially 400 and about 1,200 RVUs. So if you multiply that out by, an average physician comp per RVU rate of, let's say $50 to $75 per RVU, that becomes a tens of thousands of dollar increase or change in compensation for providers. So a lot of health systems wanted us to take a look at what their net reimbursement change was relative to the net compensation change that providers might see for those that are tied to an RVU-based compensation plan. And you can see on this table that the RVU impact is often much higher than the revenue impact. So essentially, we're talking about a disproportionate increase in the RVUs relative to what the reimbursement increases might be. Curtis, do you maybe want to say a little bit more about how that might influence the compensation plans for different organizations?
Yeah, Jason, thank you. I think going all the way back to the very beginning, as Jason showed, the Medicare reimbursement formula, from a government perspective, all a work RVU is an input in how they determine reimbursement under the Medicare Physician Fee Schedule. And then consultants and health systems kind of took that information. A work RVU obviously is based on physician time, and they used that work RVU number and said, well, if I'm going to employ a physician, I don't want the physician just sitting around. So how do I make sure that that physician is productive? And here's this Medicare number, a work RVU based on physician time. And I can plug that into a compensation model and pay a physician to keep them productive, kind of like an hour-based model. So you're not just tracking hours. It's an easy way to track it, right? I mean, you're in a billing system. Every CPT code, as Jason showed, like a 99213, which is your average office visit code, has a level of work RVUs that Medicare determined based on the specific estimated amount of time that the physician would take to do a 99213 office visit. Well, now in 2021, Medicare has gone and significantly changed those numbers around, which ultimately affects compensation plans. So the government's not thinking, what is health system A doing and what is their compensation plan? They're just thinking, it takes longer to document an evaluation management than we were initially thinking. So we're going to put more time to that, and we're going to increase the work RVUs. And then they change the conversion factor to keep it budget neutral to some extent on what the government ultimately pays out for all of Medicare. And then, as Jason pointed out, depending on the specialties and the case mix and all of those different things, that's going to affect each health system differently. So just from a compensation planning perspective, obviously, depending on what your procedural mix, compensation design, and coding practices are, those numbers might affect you differently. And so here's just a few examples, obviously, of kind of what we're seeing in the market. Like if you have a large community hospital where you have significantly more specialty care than primary care, and you have a $1 per work RVU model, you might see a significant compensation increase without the reimbursement increase. And uniquely, what we're seeing now, and I'm going to get into this pretty quickly here soon, is that a lot of people haven't been thinking about this. And now they're getting into their quarter reconciliations of productivity at the end of the quarter for March 31st, and now saying, oh my gosh, look at all this increase in compensation. You could have different models. If there's more of a mix of specialty and primary care, you might see a higher reimbursement increase and a compensation increase, or if you're primary care dominated in a small community hospital, you may see a lot more reimbursement and less comp, because you may have more fixed comp. Here you see a tiered model where you may have a higher work RVU as you hit different thresholds, or you may have more guaranteed compensation. So, what are some of the alternatives? I always struggle. Alex is a lawyer. He might want to talk a little bit more about this. Obviously, between contract law and the Stark and Kickback law, I mean, I've seen cases where people have won things based on contract law that sometimes we think are in violation of Stark and Kickback. And obviously, it comes down to language in your contracts and stuff like court systems and understanding of healthcare and all of those things. So we're not going to spend a whole lot of time on that. That's more of a legal conference than the Pinnacle Healthcare Consulting Strategy and Operations Conference. But a lot of clients have decided to maintain the 2020 Work RVU and conversion factors and rates, assuming they can just do that under their contract. I don't know, like I said, we're not going to talk too much about it legally. But what are the alternatives to that? Maybe looking at some kind of average. I'm going to give you some predictions of what I'm thinking the benchmark surveys are going to do as well. You can adjust the conversion factor to a conversion factor that may, maintain compensation at a level that's consistent with fair market value. You can move those thresholds. You can just move to the 2021 Work RVU values. Some health systems have done that. Maybe the effect isn't as huge for those health systems. So, you got to really kind of look into that, and we'll talk about how we get there. At Pinnacle, we did survey different health systems and clients and friends to try to get a sense of what they're doing with this change. And as you can see here, the majority of them have had some kind of internal planning discussions around it, but they're not planning on really doing anything about it until 2021. But that doesn't really say, obviously, whether they're holding 2020 values or they're just moving to 2021 values. But, everyone's kind of thinking about it. Just under 10% haven't given it any thought at all, and have not started making any kind of changes. So like I said, majority of people are looking to maintain 2020 Work RVU values. I've seen discussions from physician attorneys saying, don't do that. If they're required to move to 2021, make them move to 2021. It'd be interesting to see ultimately how all of that, if we're not kind of working together, has an effect on relationships going forward for those health systems. I think at the end of the day, everybody should kind of work together to find a reasonable solution and still maintain fair market value. Nobody that we surveyed said they were just going to take 2021 Work RVUs and just absorb the difference. Some people did take 2021 Work RVUs and adjusted it. I believe, obviously there are health systems out there doing it. We just didn't get those responses, I believe. I think speaking to Alex has heard of some doing that as well, moving to 2021. So we'll get there and let them talk as well. Ultimately, you need to be transparent with the physicians, conduct your diligence, consider obviously fair market value and commercial reasonableness when doing this. And I think we're going to start seeing probably some move of compensation plans away from Work RVU values, just because they change so significantly. What we have to remember is those Work RVUs are Medicare only. Some health systems have payer contracts that tie to Medicare, 80% of Medicare, 120% of Medicare. So that may ultimately affect reimbursement. Some of our clients have moved away from that a long time ago when, you had those radiology and cardiology changes that significantly affected reimbursement for those specialties. When the other payer contracts were tied to that, they said, well, we can't put all our weight on Medicare. Obviously, we're seeing a lot more telemedicine adoption. We went from 1% telemedicine to like 43% adoption of telemedicine, soon to be called digital health officially. But as Jason showed, there's reimbursement changes there, pretty significant reimbursement changes, and we're seeing a lot more models moving to that. Effect on the benchmarks, a little bit of a prediction and trying to make this simple math. On the next slide, you're going to see lower work RVU production in obviously due to COVID. I mean, we're talking about the Medicare Physician Fee Schedule here, but COVID also was a thing in 2020. That's going to ultimately affect the work RVUs. A lot of health systems try to guarantee compensation for their employed physicians, whether it's 100%, 90%, some level, but work RVUs are going to go down. So if work RVUs are down, compensation stays the same. Ultimately, compensation per work RVU goes up, right? Pretty simple math. And what we're seeing is most providers are almost fully back at their productivity levels at this point, or fairly close to it. And then you had the Medicare Physician Fee Schedule. So if you're freezing your compensation at 2020 and your work RVUs now are back up, you're going to see, if it was up, if compensation for work RVU was up in 2020 and 2021, it'll probably be back down as a result. Just some simple math here to show you how that works. If you had a physician making $525,000, performing 7,500 work RVUs in 2019, the effective work RVU is $70 per work RVU, right? So in 2020, COVID hit. We guarantee them 90% of that compensation, which is $472,500, but they experienced a significant drop because offices were closed in March and April, let's say, and you're not doing sports physicals, or you're not getting as many people coming in for the flu vaccine, whatever, all that kind of stuff is causing different disruption in productivity. People aren't coming in for elective surgeries. So that makes the effective work RVU, if you, with the 30% decrease in work RVUs, but only a 10% decrease in comp, your effective work RVU is $9 per work RVU. So it went from 70 a work RVU to $90 a work RVU due to, COVID. And then if you kept everything else consistent in 2021 and work RVUs bounced back, as you can see here, effectively, then you went from $9 per work RVU. The benchmarks are going to ask you to report actual work RVUs, which are based on 2021 fee schedule. So you're going to see a drop in the compensation per work RVU, all else being equal. So with that, I'm going to just kind of open it up to Alex and Eric to chime in kind of what they're seeing based on their conversations with other experts in the field in their position, and obviously what's kind of they're seeing in their health system. So, Alex, did you want to kick it off a little bit?
Sure. I think your survey results are pretty similar to what we're hearing out there. We talk a little bit about the contracts. I mean, there's been, a few, systems and others that I've heard of that have said, hey, our contracts kind of mandated implementation and stuff like that. But I do think the reality is a lot of organizations, especially with, kind of a robust program around this, realize that, the work RVU, I mean, you talked about it at the beginning, the work RVUs, a value of time and intensity of services that CMS establishes with a committee, and it's not really tied to how much you pay somebody necessarily. That's kind of been the work of the industry. And, I think a lot of organizations sit there and say, well, fair market value is more than just the work RVU value. So it would be difficult to justify, oh, well, because CMS did this, even though 50 or 60% of our payers aren't CMS, do we do this across the board? So, I do think it is a struggle from a compliance standpoint, from a fair market value standpoint, to kind of rationalize all of that. But then I know even with us, we've been in a planning phase of trying to figure out what did we do with the work RVU in the future? And I'm definitely a person that thinks work RVUs will continue to be important. I just don't know if they will be the driving factor moving forward. Maybe this will institute the work RVU being one of a few different factors. So I don't know. I mean, I don't know, Eric, what you've been seeing though either.
Yeah, I thought the slide in the beginning that kind of showed the illustration of the impact by different types of organizations was very important to note that not every medical group or organization is going to be impacted the same way. And that's really going to be based on the type of work that they're doing, their payer mix, the specialty mix within the organization, and then the compensation plan design. And one area when we were looking at this is that we have different types of compensation plans within our organization. And some of them are indexed to market survey data. So it really kind of goes into that administrative component of it. If you have a compensation plan that is based on a percent of the median comp per work RVU, what is that impact going to be for the next couple of years, given the changes in market survey data? I think that's going to be a challenge for several organizations there.
Yeah, thanks, Alex and Eric. I think you've hit on some really good points. One being that fair market value is at the aggregate compensation level. And, you know, I think Medicare was trying to account for the additional documentation for E&M codes, valuation management codes. But that, you know, but if Medicare pays $100 and Blue Cross pays $120 and Medicare bumped it up to $120 a payment for, you know, like your average E&M code, doesn't mean Blue Cross is increasing anything. They're still at 120. And Alex mentioned, you know, 60% not Medicare. I mean, I've seen 90% not Medicare as well. So to Eric's point, you know, the case mix can be a huge driver on how that ultimately affects overall, you know, reimbursement and compensation and everything like that. Yeah, and I think that's one of the struggles we get into, as Eric pointed out, with physicians is the compensation per work RVU isn't the fair market value, it's the aggregate compensation. And while, you know, this does drive up the potential for aggregate compensation, so there probably is additional money there for additional compensation. We're not saying it's, you know, there shouldn't be that additional compensation because Medicare is giving you more credit for time for the E&M and more reimbursement. It's not probably to the level as if you kept those comp per work RVU numbers and now change these work RVU rates, you know, 20, 30%, ultimately driving a very significant rise in compensation. And I think one thing I'd also like to point out is in the recent Stark laws, there was more of a definition of commercial reasonableness as well. And while the government did recognize that physician practices take losses and it's okay to take losses, that at some point the loss is so much that it overrides any of the benefit of the affiliation agreement. And the question is, you know, at what point does that loss create a commercial reasonableness issue, I guess, from the concern of the Stark law, which is obviously something we'll have to wait to see if it's ever litigated or anything like that. But you increase your compensation without a significant increase in reimbursement, ultimately what you're doing is driving more loss to the bottom line. And you just need more documentation on why you feel that's commercially reasonable and supportable. Okay, well with that, I think, you know, you're going to see some compensation arrangements move away from work RVU models and more toward, you know, we're hearing a lot more toward value-based. We're dealing with a group right now who's continued to grow because they provide high quality care, and the payers are actually pushing patients to those providers. They're growing leaps and bounds, not just on the Medicare ACO side, but like Blue Cross and other payers are pushing patients to them because of the quality of care and the cost of care. You know, so one way to achieve that goal is obviously through the use of APPs, advanced practice providers. And so that's becoming a more and more of a hot issue with regard to compensation plans. In certain areas, obviously the physician has to supervise. In certain markets, APPs can operate on their own. But the question is, how do we compensate physicians and create affiliation programs to make sure that they're utilizing APPs? So there's two different ways APPs, outside of obviously just billing on their own, that they may fall into the physician reports, I guess I'd say, is incident 2 and split shared. Incident 2 being under a place of service 11, your outpatient clinic not affiliated with the health system, just a freestanding office setting. And then you have your facility setting. It's all depending on how the facilities are licensed as well, which are your point of service 19, 22, 21, 23. Obviously, you see here that's off-campus hospital, outpatient hospital, on-campus outpatient, inpatient, and emergency room hospital is where you have your split shared. Going quickly through how to document a little bit of incident 2 and split shared, I have to give credit to Jody Nyoski, who's with our coding and audit group at Pinnacle Enterprise Risk Compliance Services, who put together these great slides to help explain a lot of this. But this is incident 2. How is it managed in the practice? The physician ultimately must initiate care through the initial E&M, and then the APP is involved in the subsequent care. Obviously, you need to define what type of problems are being handled. Obviously, when a patient comes in, what kind of problems can the APP handle as well. Split shared is provided by both the APP and the physician. Obviously, incident 2, the physician starts, then the APP can handle going forward. This one, it could be where the physician and the APP are even seeing the same patient in the same day. It all has to be face-to-face, different times of day by each provider. So the APP can see the patient in the morning, the physician sees the patient in the evening, for example. If the physician is not personally seeing the patient, then it's billed under the APP's provider number. Here's a couple of just quick examples of split shared. We're seeing a lot more split shared service, obviously, with hospitals taking over physician practices and licensing different areas under those place of service, 19, 20, 22, for example. And here's a great example where the patient has been seen collaboratively by the physician and the NP, and how the physician should ultimately document that they're seeing the patient with the NP. That can be billed under the doctor's NPI. Another example, as I mentioned earlier, the APP sees the patient in the morning. They consult with the doctor, reviews the record, decides what the patient needs. The doctor does a chart and orders the CT, but as you can see here, the doctor never saw the actual patient face-to-face. So this has to be billed under the APP's NPI. So why does this matter? Obviously, from supervision compensation, making sure we're not double counting the work RVUs. Where do those work RVUs show up in the rendering provider reports? It's very important to understand from the benchmark perspective what goes into their numbers. They ask for rendering provider. So is that information in there? Are you comparing apples to apples when you're looking at work RVU data? Generally we'll see compensation for APPs on a fixed amount per month, per year, per FTE. But we're seeing a lot of movement kind of away from that, because we want to incentivize the physicians to use the APPs and not just have a fixed amount. I've hired this APP, they're here, they're an FD, I'll get paid my amount, but never really use them. So we're starting to see work RVU models and stuff like that. So I'll open that up quickly. Alex, I don't know if you want to jump in and explain some of the stuff you're seeing around APP usage and compensation.
Yeah. I mean, I think you're absolutely right. I mean, I think the stipend issue is difficult because, you have some, you think about the world of APPs out there, but you've got PAs who are really trained under a general medical model. And then you have your advanced practice registered nurses, which are actually trained in family, peds, or as a nurse midwife and others. So, the question is you have some specialties where you're bringing in an APP, let's pretend it's pediatric cardiology, And there's a lot more training that needs to happen, because it doesn't matter what type of APP profession you're using, none of them are trained in pediatric cardiology. So that person, if they're, if that physician is doing it right, they're spending a lot of time training, maybe a year, year and a half, maybe two, to where that APP is optimized. Well, a standard stipend probably isn't enough to really value that level of training. But then you look at the other end of the spectrum, where you've got a family nurse practitioner who's been trained in ambulatory primary care, who's walking into ambulatory primary care. They probably don't need that much more training, certainly not 2 years. Maybe they need an onboarding program of a few months and some ongoing support. Well, in that case, the stipend probably might be too rich. So I think the difficulty is what is the level of training? What is the level of kind of ongoing collaboration and oversight? And you're going to have situations where there's a lot of ongoing training, and you're going to have a lot where there just isn't. And that's what makes this a difficult area, I think, personally.
Yeah, Alex, I agree. This is a tough area to look at, because it really depends on how are the APPs being utilized in the practice. Is it a collaboration, supervision? What type of workload are they doing? What is the training? So kind of you could have different scopes of work depending how long they've been in the practice, if it's the first year, second or third year. And then lastly too, if you kind of look at the compensation of the providers, do they have a Work RVU incentive model that where they effectively use APPs, they can leverage their own Work RVUs? You could also look at how are you calculating and attributing those Work RVUs to the physicians. So it's really important to document and understand the difference between the rendering, the billing provider, and in some cases, if you have that split share, how are you attributing those to the providers? Is it 100%? Is it 50% there? And I think really underneath the new Stark law is looking at the commercial reasonableness of those arrangements, understanding the true economic impact of how you utilize APPs within that care setting. So I know that was a lot to digest there, but those are just kind of some comments that we look at from our perspective.
Great stuff. Really appreciate the input there. So we'll jump over from APPs. And as I kind of mentioned, obviously you're reducing your costs, trying to hit that triple or quadruple aim as it may be now, providing lower cost, high quality care to all patients. Starting to move a little bit away from just Work RVUs to value-based or quality-based compensation models as well, through clinically integrated network models, efficiency programs, or just bonuses and employed compensation plans. And obviously we're starting to see a lot of physicians have some level of quality-based incentives in their compensation plan already. And just because one health system's paying 5% of comp for quality, another health system's paying 40% of comp to quality, doesn't mean that that's what's best for every entity out there. Obviously, it's based on the goals and where you are as a health system on trying to achieve certain metrics. What do your payer contracts look like? How are you doing from a quality-based perspective? And so from our perspective, from a fair market value component, we're trying to look at the different factors that drive that value. And so we have a 5-pillar system here. Obviously there's the cost of care, where are the possibilities for improvements? How do we drive that through the compensation? How does that ultimately affect your reimbursement? Whether it's your value-based purchasing, hospital-acquired conditions, hospital readmission reduction programs, those kind of things. You've got your public reporting. Obviously, improved quality will hopefully drive more patients to the hospital that may be flowing out of your community as a result of just poor quality, where they're going elsewhere to get other types of doctors or care. And then there's obviously just the internal reporting, mortality versus infections, how does it ultimately affect patients' health? And then where's the hospital want to focus their improvement? You know, where are they trying to improve? Where's the poor performance? So taking all that into account, obviously putting that into some level of compensation, I think it's important to point out the benchmark surveys that everyone looks at is just what's in the W-2. So, you know, if a doctor is eligible for 10% quality, but doesn't hit all the metrics and only earns 5% of quality, well, then that's what's in, obviously, the compensation. So that doesn't mean that you should ultimately limit the potential just because other physicians haven't hit their metrics, right? You know, we've seen anywhere from 5% for some specialists all the way up to 40%. You know, Medicare home models, a lot of value-based payer contracts and stuff like that. So with that, we only have a few more minutes here. I want to open up to Alex and Eric to kind of talk a little bit about, you know, what they're seeing in the market as far as the movement to value-based. We do have a number of other presentations around value-based care as well, which I think are really interesting that I suggest you listen to as well. But with that, I'll open up. Alex, did you want to say anything with regard to value-based care?
Sure. I mean, you know, I think it's kind of, you know, it's interesting all of this is coming together at the same time with the physician fee schedule changes and all of this. I mean, I do think that will create a much larger discussion around transitioning to value. And, you know, when I think of it, I think of metrics that are not necessarily your historical productivity based. I mean, service excellence, quality, access metrics, I mean, stuff like that. So, you know, I do think we're going to continue to see that. I mean, I do think there's going to be metrics that are more based around time. I mean, you've got some specialties where, you know, at least with us, we want to incentivize providers to spend a longer time with patients. But a Work RVU model doesn't incentivize that. So I do think inherently there's going to be a more complex way of compensating in the future, but that's in part because, you know, our healthcare delivery system's complicated. So maybe it's mimicking that. I don't know, Eric.
Yeah, definitely. I think it's evolving and accelerating that process between COVID, the new regulations, and the fee schedule. I think is going to accelerate in the marketplace. It's been growing already. The use and implementation of quality and value metrics and incentive compensation plans. I think really an important area where organizations are struggling with is data validation and the ability to administer quality incentive payments effectively. So really having that right dyad of physician leadership to consult and advise on those parameters, making sure your paid administration team can validate that data timely and execute that into the making sure a compensation is paid appropriately to the providers.
Yeah.
I think a lot of it, as we talked earlier, comes down to transparency. A lot of physicians are skeptical about this, but obviously if it creates you know, more opportunity through compensation plans, I think they'll be up for it. Obviously, you have to have the ability to administer it through your system. Big part as well. So with that, that's our last slide. I appreciate Jason, Alex, Eric, your time today, and look forward to seeing everyone on other webinars. We're around for questions as well, and happy to answer anything. Also, like we mentioned earlier, look into the American Association of Provider Compensation Professionals. It's online. You can register, become a member pretty easily. Reach out to Eric or Alex as well if you have an interest. And we appreciate everyone's time today. Have a good day.